Today I am going to tell you about endotracheal tube or ET tube. This is a 7.5 millimeter endotracheal tube. This is 7.5 millimeter because it is written here 7.5 millimeter endotracheal tube. What is 7.5 millimeter? 7.5 millimeter is internal diameter. Means this inside, when you see in the cross sections, in cross section, this diameter in a circular form is 7.5. This is a balloon, this is machine end, this is the patient end. So whenever we need general anesthesia or in an anesthesia setup, we need a general anesthesia, and in the ICU settings, when we need to protect the airway, when the GCS is low or major airway trauma, we have to insert this endotracheal tube into our larynx via mouth or nose. The procedure called as video laryngoscopy or fiber optic. So this is 7.5 mm endotracheal tube. This is curved so it can facilitate in intubation, so it doesn't come in our view. Previously I have posted some videos regarding intubation. So this is a single use, means we usually don't reuse this tubes. These are sterilized by ETO or with gamma radiations. These are the single use. So we cannot use this thing to all the patients. So we need to know how much size we have to insert, or how much, and then how much depth we have to insert. To know how much depth we have to insert, we should know the anatomy of airway from mouth towards the chest. So mouth, larynx, trachea, bronchi, and 17 generations of bronchioles. So this tip ends up in the trachea. So the marking here, number of markings are 28, 26, 24. So these markings indicate where the tube has to get fixed from the incisor tooth level. So how do we calculate? Means age by 2 plus 12 is the formula to calculate how much depth we have to insert the tube, or this tube size into 3. So if this is 7 mm, 7 3 is 21. This is the depth at which we have to fix the endotracheal tube. If you go too deep, this will enter the bronchus and will lead to collapse of other lung. If it is too far, it will be in the oral or pharynx, so the cuff will be outside the larynx, so the purpose will not be served. And how do you calculate the number of ET tube? It depends on whether we are inserting the tube in adults or in pediatrics. This is the adult size of tube. So age is the number we consider, age by 4 plus 4.5. But after certain age, the growth is limited, so the tube size becomes limited. Means it's not like 50 by 4. We cannot take the absolute higher number. So for adults, the numbers are fixed. For usually females it is 7 to 7.5, and males it is 8. So if the tube is 7 mm for female, 7 into 3, this will go up to 21 mm deep and 7 mm internal diameter. Then another is for male, it is 8 3s are 24, so it should be fixed at 24. This is if we are inserting the tube in the oral cavity. If we are inserting the tube in the nasal cavity, the distance again increases, so we have to add 1 or 2 centimeters into the oral cavity markings. This is just for calculation purpose. Clinically or in a patient settings, we have to adjust it according to height of the patient, neck of the patient. It's a decision of the healthcare provider who is using this ET tube. The points to remember is, this is a curved ET tube, this is having the cuff, this is the pilot balloon to inflate air or saline depending on whatever you are using. Then this is curved tip to avoid injury, there is an eye, this is ET tube connector, this is the patient tube. So tube number is the internal diameter of the ET tube. If you want to, if you know the number of the tube, you can understand how much deep you have to go. So the 7 mm, 7 3 is 21. So if you are using 7 mm ET tube, the depth of insertion should be 21 millimeters. This is in short about endotracheal tube. There are many more points, but for practical purposes we should know which size to use, how much deep we have to go, and once it goes in, we should know to confirm whether it is in the airway or in the food pipe. Food pipe means esophagus. If it is not in the place where it should go, it will not help the patient. This is the device which we inserted through mouth or through nose, through the pharynx, it goes into larynx, into trachea. Once it's inside the trachea, we confirm it with auscultation, 5-point auscultation, 1, 2, 3, 4, 5, the abdomen to exclude esophageal intubation. Then we confirm with ETCO2, and in an ICU setup we use a chest X-ray to see the position of ET tube. Means once we intubate the patient, immediately the patient need to have a chest X-ray, AP or PA view, depending on the setting of the how is the patient condition. And using an adequate size is important because it reduces the resistance and hence work of breathing is reduced. So larger the size, less is the resistance. To know more about this resistance concept, we need to know Eigenpoison's formula, which we'll discuss in some other day.